Dear friends, welcome to this new video. Today we will discuss a case of retinal detachment in a myopic patient with a relatively posterior vitreous base and a fairly large eye. Here you can see the tear in the superior temporal quadrant, which is also quite posterior, located within a small lattice degeneration. Since there was some bleeding, we quickly performed a coagulation of the bleeding vessels, which also helps mark the tear to ensure it remains visible during surgery in case we encounter difficulties. Now, we are completing our vitrectomy under indentation. The most important aspect of any retinal detachment is to properly identify the vitreous base and shave it down as much as possible to limit the risk of postoperative retraction and redetachment. In this case, we observed multiple lattice degenerations. We must be meticulous in our surgical approach, shaving as much as possible under indentation while carefully visualizing the small holes in the lattices. If we have any doubt, we generally perform laser treatment around the lattices. Next, we will slightly shorten the anterior edge of the tear, completing the vitrectomy a bit anterior to the tear. Once the vitrectomy is complete, we can begin our fluid exchange. This will enhance our peripheral vision under air as it helps flatten out the peripheral area. For a good fluid exchange, it's ideally best to create a central air bubble for improved visibility before addressing the tear directly, where we will aspirate all the subretinal fluid from within the tear, closely monitoring the transition level between the air and the fluid, aiming to aspirate as much fluid as possible. If necessary, we could use perfluorocarbon liquid, but we wanted to avoid that in this case because the eye was quite large, making it more difficult to recover the perfluorocarbon at the end. We can also slightly orient the patient's head by turning it, although this is not always feasible, so we managed to perform a more or less satisfactory fluid-air exchange. Now, we will perform laser treatment around all the lattices that appeared pathological. We will use a sufficiently wide laser beam, not too intense, since these patients generally have fragile retinas. Performing this under indentation helps mark the retina, as sometimes the laser does not properly mark the posterior margins if there is residual fluid. Therefore, having an assistant who can indent can sometimes make this easier. We now complete the laser treatment around the identified pathological lattices. There's no need to do more in this context. For more posterior detachments, it's better to perform some laser treatment rather than cryotherapy, as it is easier to reach without risking burning undesirable areas. Once our laser treatment is complete, we can finish our fluid-air exchange. We will aspirate the remaining fluid and now perform our air-gas exchange. I believe we used C2F6 gas. Since this was a first vitrectomy, it is usually relatively watertight, but in myopies, this is sometimes not the case. Indeed, in this patient, the scleral thickness might have been too thin, making it insufficiently watertight despite good tunneling. Therefore, we sutured our sclerotomies. For complete tamponade, it's essential to have a thorough vitrectomy with a complete air-gas exchange and perfectly watertight sclerotomies to avoid postoperative leaks. I hope you enjoyed this video. Feel free to comment, and thanks for watching.